need to know what are the advantages. You are ideally replacing just the anatomical structure which is abnormal. You end up with faster visual rehabilitation. You end up with better visual recovery. The astigmatism is less, rejection risk is less, refractive change that you're inducing is less. All the benefits of a small incision surgery with respect to expulsive hemorrhage risk, globe dehiscence is less. If it fails or it rejects, the resurgery is simpler. So if you ask why DMEK, why not a PK, this eye, if you look at it and you see a significant scar, you see a significant vascularization, you see it's primarily an epithelial hypertrophy, you have endothelial changes also which is causing the decompensation, you have a scarring at the deep stromal level. Yes, you could have done a PK and got back vision, but that would have been a high risk graft with the induced astigmatism that a PK gives, with the risk of a globe dehiscence with trauma. And when you can get a result like this with a 6/6 partial vision with a DMEK, why would you want to do a PK? And you can see the significant improvement to the extent even the vascularization, which was primarily secondary to the stromal edema, significantly regress, improving the visual outcomes and reducing the risk of rejection. So the question should be not why DMEK, it should be why not in all cases that you see where you primarily have an endothelial decompensation and you can address whatever anterior scarring or epithelial hypertrophy is there with a bit of maneuver, either by removing the epithelium or by doing a PTK to remove the scar and improve the visual quality. So when you compare to PK, we've already mentioned what are the drawbacks of PK, whereas when you compare it with the similar procedure in terms of a DSEK, which is also a small incision surgery, the anatomical replacement is with the stroma as far as DSEK is concerned, so that does induce a bit of a refractive change. The visual recovery is a little bit slower as compared to DMEK, even though there are reports which state that if you do ultra thin DSEK or a nano thin DSEK, the results are comparable to DMEK, but DMEK gives you a faster visual rehabilitation, and in terms of rejection with both DSEK and DMEK, the rejections are almost similar. Indications are primarily for eyes with endothelial dysfunction, but if somebody is starting off endothelial keratoplasty, it is easier to start off with simpler cases. Fuchs would probably be the most ideal case, especially if it's already had a cataract surgery done and has a decompensation now. It's a lot easier because the Descemet's stripping is much more simpler. There is some amount of healthy cells in the periphery, so even if you end up traumatizing your tissue, the outcome is generally much better in Fuchs as compared to a pseudophakic bullous keratopathy, where it involves a significant damage to the entire endothelial cell population in that eye. How to become a DMEK surgeon would be to first read up about the procedure. You would want to see all surgical videos that are available, and now with YouTubes and conferences and online meetings, everything, you do have a backup of tissues in Facebook, various groups where you can look at various surgical procedures, surgical tips that are shared by the experts. It is better to actually meet a DMEK surgeon, sit one-on-one, have a conversation, understand the nuances of the procedure, attend wet labs wherever they are conducted, whether in your national conferences, international conferences, specialty conferences. See live surgeries as much as possible when it is done. You have the option of attending specific courses which they take with respect to DMEK. And once you have learnt about it, you have read about it, you have seen videos, and then you are ready to start, then your case selection is important. Select a simple case. Be ready with a bailout package in case you end up having a problem with DMEK. You should be comfortable doing DSEK. You don't want to do a PK in these eyes. If possible, get a mentor to be with you, especially in your first case. Initially, when you are doing it, you would need a backup tissue because you might damage the tissue while preparation or injection. So it's always a bailout in terms of having a backup tissue to do DSEK. Nowadays, with the availability of pre-stripped or preloaded tissues, that could also be an option, but again, there is a cost component to that, and even now in India, we probably just have the pre-stripped, we don't have the preloaded tissue, which is available in the West as such. In terms of before you start it, obviously practice, because that's what's going to make it perfect. You don't want to be trying out a new stunt on the patient's eye. You want to be absolutely certain as to what you want to do. So when you're doing the preparation of the donor tissue, any of your DALC cases, you can actually strip the DM like you would do for a DMEK so that you get a feel of the tissue. If you are discarding any of these eyes because they're not being used for a particular reason, you can practice stripping the DMEK in those DMEK tissue in those eyes. You can try various techniques of preparing the tissue, and the idea would be to know various techniques, but you master one. So that is going to be your primary way of preparing it. But if there is a problem in that particular eye, in that step, you should be able to switch over to the next technique so that you are able to harvest the tissue without losing the tissue. Loading, again, you have the option of both glass injector, plastic injector, and you also have the option of loading into a cartridge like an Endoglide, or in terms of one of the ICL cartridges with a stopper, and you can do a pull-through technique like we do for a DSEK. In terms of simulation, you can have various options. So in terms of donor preparation, in terms of preparing the tissue in your practice, any of the discarded eyes can be used. You can mark the trephine with a 100 micron trephine peripherally, strip it and try to peel it off, and then once it's partly peeled, you make a 3 mm punch window which will allow you to mark the stromal side of the tissue, and then you take the central 8 mm or 7.5 mm punch. If there are ways of doing it where you can start peeling it off from the Schlem's trabecular meshwork and the Schlem's canal, so that you get the DM in a complete peel. What is important when you're preparing the tissue is to keep it wet. The moment it dries, because of static friction, there will be a tear. You always have to look at the D when you fold the tissue, and if the D line is straight, you know that tension is equally distributed and it is not going to tear. If you feel it's kind of becoming like a V, then you know that at one point it is adherent, and trying to pull it up more in that area will lead to a tear. Always look at the edge and at the line where you are pulling it to be sure that you don't end up tearing the tissue. If you have a tear in the periphery, you can actually convert it like what we do in our X's, in terms of you can just make it the reverse cut so that it's like a crescent and it doesn't extend further. So it's important to notice this when you are pulling the tissue. The other way of practicing it would be in animal eyes, like a goat's eye or a porcine eye. You can actually remove the anterior capsule of the goat's eye in terms of the cataract. You can stain it with formalin so it kind of stiffens, and then you can use it, because then the consistency becomes similar to what DMEK scroll is. You can do that even with the anterior capsule of cataract that you do a rhexis, but it's a smaller disc. It's only 6 mm, so it doesn't get you the complete scroll feel that an 8 mm tissue will give you. So with a porcine eye or with a goat eye, you can actually take a larger rhexis size, and that gives you the advantage of trying it out. The other option would be to peel onion and make a very thin strip of the peel of onion, which will again tend to scroll like a DMEK scroll, and you can use that as practice when you're practicing in the wet lab, trying to unfold it if you have issues with access to human tissue. One second. So the next step would be in terms of when you are preparing the tissue, and before you load it into the injector, you need to be sure that you are marking it, because you need to be certain that you are inserting it in the correct orientation. So you have different ways of identifying it. One would be to put your F stamp or your P stamp on one side after creating a stromal window. Other option would be to just cut one edge of the DMEK tissue like an arrow, and you always know which side the arrow is going to point, whether it is going to point clockwards or anti-clockwise, so that you know that the orientation is correct. Generally, there is a tendency of the scroll to scroll with the endothelium out, so you can actually do the surgery even without marking. But in a cornea which is edematous, marking gives you the added precision required to be sure that you have not inverted the tissue inadvertently. When you're practicing injecting into the eye, obviously again you can do it in a whole globe in terms of discarded globes, or you can load it into an artificial anterior chamber. Now the only thing is, an artificial anterior chamber has a depression in the center. So if you just try to inject the DMEK scroll and try to unfold it, it doesn't, it sits at the base. So it's nice to actually cover that with a gloves, preferably a white color gloves, which kind of gives you the contrast between the blue stained DM and the base. And that acts as the iris diaphragm, allowing you the access to flatten the chamber and allowing the tissue to unfold in the manner that you would want to. And this has been published by Dr. Rajesh Fogla. In terms of the goat size or human eyes, it's similar. You can remove the lens and inject it and unfold the tissue using various techniques which have already been popularized. Loading the tissue, you can load it from the smaller part of the pipette, you can load it from the back side of the pipette, you can load it, you can fold it and load it with the endothelium in. Try all the types of loading that you can do. Always, if there are 10 ways of doing it, do it all the 10 times. See which you are most comfortable with, and then just keep doing that one test one way so that you perfect that before you go on to the next way of doing it, but you should be aware of all different ways of skinning the cat. Last would be to inject the tissue. Once you have loaded it, it's important to see the orientation of the tissue. So it goes in a double scroll or a single scroll. It's like a dosa, it folds. So you need to see the angle that is created. So the triangle with a base down indicates that it is going in the correct orientation. So near the pipette tip, it has to be a base out. Near your side, it has to be a base out. That tells you that you are in the correct orientation. You inject the tissue without too much of force so that it goes in that correct orientation, and then you are able to open it. So this is just a video showing the opening up in terms of how you would want to open up the tissue. So you can then pin it on one side and tap either on it like a carpet rolling method, or tap peripherally to unfold the tissue. And once the tissue is unfurled, you can inject it. So this video by Vikas Mittal just kind of tells you the maneuver that you need to do once the tissue is inside. So to conclude, if you are starting on your procedure, read literature, attend labs, meet with mentors, practice, identify the ideal patient, and that will help you conquer the surgery. Thank you.
Thank you very much for those insights, Dr. Bhaskar. Any questions from the audience?